I introduce second speaker. Second speaker. The second speaker is Dr. Yamamura. Yamamura is a graduate from Yamamura University, 2002, and he was number one of specialist of lower GI. And now he works at Yamamura University Hospital. He likes Thailand, Bangkok. I don't know why. Please start.
Thank you for Professor Goto. Nice to meet you, everyone. So it's a great honor for me to have the opportunity of this presentation. Thank you for the Professor Somchai, Professor Goto, and the Fujifilm Company. My name is Takeshi Yamamura. I belong to LGI Group of Nagoya University. First of all, so Professor Somchai, congratulations on holding the APDW 2023. I visited Thailand for the first time in the 3 years since the corona pandemic, and have a great time in Bangkok, which was as vibrant and fun as ever. It is a great pleasure that Professor Somchai approached us, and we could take a photo together. When we recall, the first FDW I attended was a conference in 2012. Maybe Professor Taui present? So it has passed more than 10 years since then. So I was young at that time, and Dr. Miyahara Kawashima also looked young. And the first time I came to the Siriraj Hospital was in 2016 with Dr. Hara. And I remember being impressed with what a very big and wonderful hospital it was. So of course we are very happy to revisit Siriraj Hospital again. Thank you for Professor Goto, always support us. Let's start the presentation today. I prepared 2 topics to speak. First, so difficult case in colorectal ESD. This paper shows the result of the multi-center cohort study of the colorectal ESD in Japan. Mean procedure time 80 minutes, embryo resection rate 1960.90%, perforation rate 2.6%, emergency surgery 0.5%. This study indicates a more reliable outcome than previously reported. So, LGI ESD can be the first-line treatment for the large colorectal region with acceptable risk and its good result. The table shows the current selection of the endoscopic treatment in LGI. Recently, there was a slight change in the borderline region between the EMR and the ESD. The adaptation of EMR is expanding to use a modified EMR method. For example, the pre-cutting EMR, underwater EMR, chip-in EMR. A new method as modified EMR was reported. With regard to the ESD, the regions that were difficult to resect endoscopically in the past can now be resected by using ESD. In general, the indication for the endoscopic treatment was still expanding. Today, I introduce 2 kinds of procedure we perform. Case 1, so appendiceal region. Appendiceal region was a new indication for ESD. I will show you some image of the case. Cecal region invented is appendiceal after the appendectomy, and covered more than half of the appendiceal office. The boundary of the region could be seen when a scope was inserted into the residual appendix. The region embedded the appendiceal office partially and covered more than half of the appendiceal office. So first, the local injection was made around the appendiceal office, including the region. Next, circumferential incision was made around the appendix. And I performed submucosal dissection after the circumferential incision. After trimming, an incision was made from the anterior side towards the center. And the dissection was gradually widened while the treating small blood vessel. During the dissection, the objective was visually identify the remaining appendix. Fortunately, I was able to resect the remaining appendix without using traction device in this case. So I suspect the appendix office located in this area. Sorry, don't work. And so we can see the ulceration after the ESD. The pathological result was in intramucosal cancer without lymphocytic invasion. So we accomplished the curative resection. So fortunately, Dr. Weapon has worked with us and learned to treat difficult case. She summarized the special ESD case in review. Please ask her. I introduced a unique case happened occasionally. There was an LSD with an intra-appendiceal extension with a history of appendectomy. The ESD went well up to the middle of the procedure, but the publication occurred in the last stage. We hastily dissect the remaining tissue around the appendiceal office. In the result, we are able to resect the appendix en bloc endoscopically. The pathological specimen was fixed and inverted position and show a firm appendiceal transection, which ultimately resulted in the endoscopic total resection of the remaining appendix. When you find the lesion involving the appendiceal office, you have to check the two, the history of the appendectomy and identify the lateral margin of the lesion. If there is no history of the appendectomy and the lesion extends into the appendix, we must talk about the possibility of not being able to remove. If the appendix have not been resected, it is not easy to draw the appendix completely into the intestinal side. So it is difficult to complete en bloc resection without appendectomy. But there are some reports. Normal endoscopist can totally resect, so intact appendectomy. But it is not always. So now let's move on the another procedure. PEM. Let's move. I will show the recurrence tumor after the transanal resection in the low rectum. It seems to be very tough to resect endoscopically because severe fibrosis was predicted. We selected the PEM, anal endoscopic mastectomy, as a method for this lesion. PAM is a technique to dissect between the inner circular and outer longitudinal muscle under the submucosa. The future of PEM including the following. Especially so RZ resection is possible even for the T1B cancer. We decide the indication of the PEM. We perform a CAM when a tumor depth is considered T1B. And for the recurrence lesion that are expected to be highly fibrotic. I will show the video how to treat the severe fibrosis. I can move, sorry. Next image. In such case, it was important to decide dissection line upon the muscular propylia. But it is difficult to distinguish a muscular propylia in this situation. After I pounded the impossible situation, I changed the strategy to peel the inner muscle layer. In this image, I attach a real muscular propylar line with a blue color. But it is very difficult. I accomplished the en bloc resection with dissecting the inner muscular propylia. In the pathological result, there were severe fibrosis under the lesion as we imaged it. Although we could complete en-bloc resection with a sufficient tissue. As shown in the black box, the part of the muscle layer was removed with the lesion. In your study, the table shows the result of the PAM for the T1B carcinoma performed at our hospital. We could complete en-bloc resection negative vertical margin for all T1B cancer. I consider it to be the effective treatment for the T1B cancer of the lower rectum. Today we talk about the ESD for severe fibrosis lesion of the appendiceal lesion. There's a still topic left, so I will talk about that another time. Now let's change the subject to the AI, which is becoming popular in endoscopy, as Dr. Miyahara said. The reason for the overlooking the lesion is caused by poor visibility. As the audience will understand, so both pictures were examples of the lesion with low visibility. They will be missed easily. The lesion there was likely to miss the diminutive polyp or flat lesion or the little color difference. AI can support to dissect this lesion. CAD-E. Fujifilm has developed the cutting-edge image processing the technology named CAD-I. CAD-I have been training with a powerful supercomputer located in AI technology. As a result, CAD-I is a customized detection and characterization by using a deep learning technology. In detection support, CAD-I is aimed to improve the real-time polyp detection rate to expert level, helping to recognize flat lesion multiple polyp simultaneously. In characterization support, CAD-I can support the diagnosis of the polyp in combination with BLI. This function analyzes in real world and without freezing or zooming. If polyp is a hyperplastic or neoplastic polyp, which is visually indicated the use of the different color in the position map. So yellow is neoplastic, green is non-neoplastic. CAD-I characterization is aimed to make a procedure more efficient by increasing the accuracy of diagnosis to the expert level. Current AI effectiveness is divided into the three parts. So detection, CAD-E, characterization, CAD-X, and quality assurance, CAD-Q. In detection support, CAD-I detection is possible with white light and LCI mode. In characterization support, CAD-I can work in the combination with BLI, with or without magnification. I usually use the CAD-I with BLI with magnification by using a genetic classification. In my opinion, BLI with magnification seems to be a little more correct in CAD-X. I summarize the first effect AI have diagnosis and checking the previous report. So several RCT have been conducted on adenoma detection rate ADR. Of course, ADR is the strongest procedure predictor for CRC risk and a key quality indicator of colonoscopy. In RCT, CAD-E have a significant higher ADR compared to white light. ADR elevated from the 20% without the CAD-I to 29% with CAD-E in practice. In this paper, not only ADR, but also polyp detection rate and also the mean number of adenoma considered the number of the higher with CAD-E compared to the white light. RCT also demonstrates the ability of the CAD-E with high level of evidence in many reports. And the meta-analysis with high level of evidence for CAD-E have been also reported. ADR significantly improved for AI in all reports. I would like to explain the main outcome. So ADR increased to the 36% with CAD-E from 20% 25% without CAD-E. The CAD-E have about 10% add-on effect in ADR. It seems certain that the CAD-E have an add-on effect to the ADR compared to white light image. This study elevated the characterization to check the accuracy of the CAD-X characterization by IEE without magnification. When using BLI for characterization, the accuracy of expert and CAD-X were almost 80% similar. Otherwise, so non-expert plus CAD-X shows a compatible accuracy with significantly lower specificity. CAD-X have a great power in non-expert characterization. I would like to show the video of CAD-E in practice. In CAD-E, when the CAD-E finds a region, a tone sound and the region is surrounded by the circle. In CAD-X, when the endoscope changes the mode to BLI, CAD-E starts characterization of the region after detection. Show the light color image when the area of polyp turns yellow. CAD indicates the region as a neoplastic region. On the other hand, the green is indicated as a non-neoplastic region. Okay. I want to show the movie of using a CAD eye. If the CAD detects a polyp, it makes sound. Don't sound, sorry. The region is surrounded by the square. So with BLI mode, CAD starts to diagnose the region without magnification. After using magnification, CAD keeps the decision as a neoplastic region. Endoscopists can diagnose it as a JNET2A and pit pattern 4. CAD and endoscopic diagnose the region as adenoma. Second, so flat region 8 mm in size at a sigmoid column detected by CAD-E. Endoscopists detect it little after. LGI emphasizes the color of difference. The region was diagnosed as a neoplastic with magnified by CAD-X. Endoscopists diagnose it as a JNET2B and the pit pattern 3L. Histological of this polyp shows a high-grade dysplasia. So third case, so final case. So very little polyp. Experts suspect that diminutive polyp with a low confidence, but CAD don't respond. In BLI mode, expert was convinced that the little region was present. With close to the region, CAD recognized the polyp and immediately diagnosed it as a neoplastic region. Endoscopist is me. Summary, so CAD improves the ADR and decreases the AMR. So CAD have similar ability of experienced endoscopists to characterization of the colorectal region. AI is support tool of the detection and characterization in colonoscopy. Thank you for your attention.
Thank you for wonderful presentation, including AI. Very advancing. Thank you. After our discussion.
มาเลย Thank you very much, Professor Miyahara, Professor Yamamura for excellent talk.